Thank you, Professor Liang. Thank you for your kind introduction. And I would like to thank the organizing committee to give me the chance to give this presentation. The topic I will give today is the hypoidentical hematopoietic stem transplantation for hematological malignancies. I'm from the Peking University, and we have the largest bone marrow transplantation program in People's Republic of China. Therapeutically, I shall talking about the in vitro T-cell depletion for hypoidentical transplantation, and I will then non-myeloablative hypoidentical transplantation, and amyloablative myeloablative hypoidentical transplantation. This is mostly based on our data. Because of time limit, I will focus only on part 3. As I mentioned before, that in recent years we use GIC protocol for hypoidentical transplantation. This protocol was very nice for induced immunotolerance. The GCSF plays a central role in this protocol. We think that because GCSF, which not only was a mobilizer of stem cell, but actually it can increase the PDC and also mononuclear cell, and also the GCSF can regulate the T cell function by downregulation of CT28 or 7 signal. Not only the GCSF in vitro TCSF ablation can affect the bone marrow harvest, but also affect the peripheral blood harvest. And also the mixture of GCSF mobilized bone marrow harvest and the GCSF mobilized peripheral harvest can keep the hyperresponsivity and the polarization of T cell. And that's why we think that the GCS property was very important. We have a serious publication before, and the engraftment is very good, and also CD34 number affect the engraftment speed. Here is the characteristic of graft. Although the rapidly engraftment because the graft have a lot of number of CD3 cell. That's 1.7 times 10 to 8. That's also indicated that our transplant was amended, but at least not in vitro this depletion. Although the CD34 number was not very high, only 2.6 times 10 to 6. The incidence of GVHD was accepted, although the totally accurate the incidence of GVHD is nearly 50%, but the severe incidence was less than 20%, around 12%. It seems the incidence after hypoidentical transplantation was significantly was higher than simply donor transplantation, but there's no significant difference. Also, our data indicate that the incidence of GVHD was no relationship with the degree of HLA disparity. This here we means ABDR. The disease-free survival is comparable to the HLA identical simply donor transplantation. That's actually in my last abstract also indicated the result is very good. We also compare the hypoidentical transplantation with unrelated donor transplantation. That it seems that after hypoidentical transplant, the relapse rate was lower than unrelated donor transplantation, especially in standard risk patient. The relapse rate was significantly lower after hypoidentical transplant compared to patient received unrelated donor transplantation. We also compare the result for high-risk patient. That means the patient received transplantation over CR2 or in refractory or relapse state, that the relapse rate was significantly higher after identical HLA identical single donor transplantation, and the disease-free, however, and the overall survival was significantly higher after hypoidentical transplantation compared to a patient received HLA identical simply donor transplantation for high-risk patient. So based on this data, it indicates maybe hypoidentical transplantation have zero graft-versus leukemia effect, at least for high-risk acute leukemia. Because of the very good clinical result, the number of hypoidentical transplantation continuously increased in our institute. And in recent year, nearly 60% of all allogeneic transplantation are hypoidentical transplantation. This is some data and published, and also some other group also. And this protocol was widely applied in other centers in mainland China, according to the registration of Chinese hematopoietic stem transplantation in 12 transplant units, that nearly 30% of allogeneic transplantation are hypoidentical transplantation. So we can conclude from this data that GCSF mobilized bone marrow harvest combined with peripheral blood harvest from hypoidentical family donor without in vitro T-cell depletion might be used as a good source of stem cell for allogeneic transplantation. There seems no difference on all over survival leukemia-free survival between a patient received hypoidentical transplantation and unrelated donor transplantation. Then the next question we need to answer is that whether for high risk or standard risk AML allogeneic transplantation, hypoidentical transplantation is better than chemotherapy. And actually, we have some data indicating that hypoidentical transplantation is actually better than chemotherapy. So the next part I will talking about the strategy to improve to improve the clinical result. I will focus on the donor lymphocyte infusion. Also, I will mention about manipulating the graft, optimize the care, ligand, or improve immunoreconstitution. As we all know, relapse remains a problem even after hypoidentical transplantation. This is our data indicating for high-risk acute lymphocyte leukemia. Even after hypoidentical transplantation, the relapse rate was very low, very high. So in recent years, we have modified a traditional donor lymphocyte infusion, including we use GCSF primarily peripheral blood progenitor cell harvest instead of steady donor lymphocyte harvest. And also, we use short-term immunosuppression agent, mostly use cyclosporin A or MTX for prophylaxis of DLI-associated GVHD. By use this protocol in HLA identical simply donor transplantation, we have data confirming that the short-term immunosuppression agent, addition of short-term immunosuppression agent can significantly decrease the incidence of donor lymphocyte infusion associated GVHD. So we try to use this modified donor lymphocyte infusion in HLA hypoidentical transplantation for high-risk patients, try to advanced stage, actually this is also high-risk patient, try to decrease the relapse rate. This is retrospective data, totally 75 patients. This is the time of prophylaxis donor lymphocyte infusion. This is the cell number. The cell number is nearly 1 to times 10 to 8. So this is a larger number of T cell infusion. Our data indicate confirm our previously data in HLA identically similar donor transplantation that indicate after the donor lymphocyte infusion, for more than 6 weeks, 4 or 6 weeks short-term immunosuppression agent can significantly decrease the instance of donor lymphocyte infusion associated GVHD. And in patient received the prophylactic modified donor lymphocyte infusion and without the donor lymphocyte infusion, the instance of GVHD was almost the same, and also the instance of chronic GVHD also seems the same. At least no significant difference, and treatment-related mortality was almost the same between these two groups. But the relapse rate was significantly lower in patients received prophylactic donor lymphocyte infusion. And the patient received the prophylactic donor lymphocyte infusion has significantly higher probability of all-over survival compared patient without the prophylactic modified donor lymphocyte infusion. So we conclude that actually with modified donor lymphocyte infusion for after hypoidentical transplantation for high risk leukemia can significantly decrease the relapse rate and increase the survival. Actually, we also use this strategy for standard risk patient. The story is that for standard risk patient, we use MRD monitor to series monitor. If the patient have MDR positive, they can either receive the interleukin-2 for treatment or receive the donor lymphocyte infusion. We can find after donor lymphocyte infusion, the relapse rate was significantly decreased compared to the patient with interleukin-2, and also it seems that this is the standard risk with monitor MDR negative group. It seems that after donor lymphocyte intervention, the relapse rate was similar to the patient with negative MRD, and also the disease-free survival was significantly increased compared to the interleukin-2 group. So this paper has actually been accepted by Blood and has been online published. So we can conclude that actually modified donor lymphocyte infusion can be used for the treatment and the prophylaxis of relapse even after hypoidentical transplantation. And also we have data indicated the cell component of graft can predict the instance of GVHD as shown by this slide. The high cell 1 group have higher instance of GVHD. There have many such kind of data based on our data. And also we have mice model indicating that when we use interleukin-11 combined with the recombinant G-cells of mobilizer, they can change the cell component of graft very different, and also the patient received the combined mobilization have a higher disease-free survival, compared even higher than only use GCSF stem cell mobilizer. So it indicated that maybe we can change the mobilizer to further change the graft cell component, and might be to induce the immunotolerance, might be get a better result. Although as we know, interleukin 11 is relatively toxicity, but actually we have new mobilizers such as CXCR4 antibody. So maybe we can by changing this can better result. Also, we are very interested in cure-like mismatch to the overcome, as reported by Dr. Avas, Italy group, that the cure mismatch have lower instance of GVHD, lower instance of relapse. But in our protocol, we found that the cure mismatch, higher instance of GVHD, higher treatment-related mortality, even higher relapse rate, the lower the disease-free survival. So at least for our protocol, when we chose donor, we need to choose the cure like matched, not mismatched donor. And finally, we all agree that immunoreconstitution is very important, because the rapidly immunorecovery will with better disease-free survival, at least for this is indicated for absolute lymphocyte count. We compare the recovery of T cell between HLA-identical transplantation and hyper-identical transplantation. We found it seemed the CT3 reconstitution was similar between hyper-identical and transplantation and HLA-identical simple donor transplantation, but CD4 reconstitution was significantly behind the HLA-identical simple donor transplantation. So novel approach to improve the recovery of immunoreconstitution are greatly required. Maybe interleukin-2 is a good choice. Actually, we initially randomized the clinical trial to evaluate the interleukin-2 after hyper-identical transplantation in our center. We hope maybe at the end of this year, maybe we can have some preliminary data. I would like to thank my colleague for this contribution to this work. Thank you for your attention.
We have 2 minutes, so I would entertain 1 or 2 questions. Any burning questions before the question time at the end?
I think so, Dr. Huang, this is always tantalizing data to look at this. I think from our perspective, are you ready to recommend for a patient with high-risk leukemia who had a sibling donor to actually do a haploidentical using the GIIC technique?
Yeah, actually, in German last month, also a doctor asked the same question. But my answer is that I still will choose the simple donor transplant donor, because it's more simple, it's more easy to do. But and also we need more data to confirm. If we have initial prospectively study confirm the result might be, we can switch to the hyper-identical donor.
And during the last session, you were asked if you would, what the donor would you prefer, whether the father and the mother, and you had said that your data suggested that the male parent was appropriate. How about if there was a male child available with between a young male haploidentical and an older parent. Do you have a feeling? Is there a benefit to do? Because your initial data suggests that looking at younger haploidenticals, you get less graft versus host disease by using the child. How about, would it make is there a benefit of using the child as a donor over the parent?
Yeah, might be better. Actually, I have also the similar feeling, but we need to further analyze the data. Yeah.
Okay. Just a quick question about how many of your donors are really parents? What's the average age of your patients in this setting, and how often do you use parental donors versus siblings or children?
You mean the age of patient?
Yeah.
The middle age of patient is actually around 30, more than 30 years. I cannot remember exactly. Most of patients are adult patients. The older age is, in our center, the oldest patient received hypertension is 64 years old.
Okay, thank you very much, Professor Huang, for the excellent presentation.